Hello and welcome to another episode of The Rest is Plastics. My name's James Chan.
And I'm Anton Fries.
Robbing Peter to pay Paul is the topic of today's conversation, but in the context of the free fibula flap reconstruction. The paper today is called Ankle Instability and Gait Disturbance After Free Fibula Flap Reconstruction in Head and Neck Cancer Reconstruction, a systematic review.
We spoke to the authors of the paper, Sebastian Holm and Juan Berner. Dr. Holm is a PhD student and plastic surgery resident at Örebro University in Sweden. Dr. Berner is an assistant professor and medical director of complex reconstructive microsurgery at University Hospital in San Antonio in Texas. It's a really great paper and I hope you enjoy it.
Okay, so Juan and Sebastian, welcome to The Rest is Plastics. Thanks so much for joining us to speak about your fantastic paper. If you don't mind, I'll ask the first question. Sebastian, why did you choose to study this topic?
I first want to start with me and Juan. We did some collaborations before, and our first actually systematic review was published in JPRAS, but it was a letter to the editor. So now I have my chance to give some commercial for that paper as well. It's called Unknown Effects of Nicotine Pouches Snus in Plastic Surgery. Lessons from a systematic review. So basically there we talk about snus via smoking. So this is some commercial for the audience, and it was published in JPRAS as well. So, but we started that collaboration. It was our first systematic review, and I'm doing my PhD now. And me and Juan, he's one of my supervisors, and we were always discussing the bone reconstructions for head and neck, and we're especially talking about donor morbidity, donor site morbidity, and we especially talked about ankle instability and gait disturbance, as we could see that this usually is inconsistently reported and also poorly standardized. And I meet patients as well that ask me the quite a good question. Is it how will this reconstruction with the fibula flap affect my long-term walking? Will I be able to walk after this type of surgery, which is a relevant question. And we could see in the literature when we looked at it that there's a high flap survival, especially for the fibula free flap. But usually the long-term leg issue is usually from minimal to meaningful, and there was really heterogenic different reviews that said different results. So that's why we decided to do a PRISMA compliant systematic review, and we wanted to look at specifically ankle instability and gait disturbance. I also wanted to add, especially when we talk about this and the question the patient asked, for example, will I still be able to walk normally, which is a relevant question. And also it's important to talk about the donor site morbidity, I think, because we usually talk about flap survival, and we talk about how good are the flap survival rates. But I think a really important question is also to ask, what is the donor site morbidity success and the survival of the donor site? And I think that's really important, especially when you decide which type of flap you want to use.
Thank you, Sebastian. That's a really good insights into why you went and did this study. The thing that caught my eye was that you were talking about one of the workhorse flaps that we use for head and neck reconstruction. And I remember in my fellowship, we did a lot of head and neck reconstruction in Taiwan, and the fibula flap, of course, is one of the most commonly used ones for bony reconstruction. And it's one of the topics that we always talked about. What is the donor site morbidity? And it's great to see that you've looked at this systematically. Now, you say now this is your second systematic review. Can you now tell us, how did you decide what papers to include?
Yeah, so firstly, we tried to design a PRISMA compliant systematic review. So firstly, we decided to do a protocol in Prospero, and we got the help from like a health science librarian to do a really broad search. And we are thinking first which type of free fibula flaps we should include. And we wanted to we knew before that the literature would be heterogenic. We had at least a hypothesis that would be heterogenic. So we wanted to try to pick a homogeneous group, and that's why we focused on head and neck cancer reconstructive patients. So we didn't include trauma, we didn't include benign reconstruction with free fibula flaps, and that's one of the main reasons was to have a homogeneous group. But also, it's a very interesting group to look at because these patients, as we know, are usually older, a lot of comorbidities. We know that the donor site morbidity have more complications in this older population usually, and that's also one of the main things because theoretically, if we talk about the pediatric population, if there, I would expect to see less complications of the donor side after free fibula flap, because in those cases they're usually young, they don't have comorbidities, and they have a better healing abilities and less, for example, less wound complications. So that's also one of the main reasons why we decided to pick this group and to pick these type of studies for the search. I don't know if Juan want to add something on that.
No, I think Sebastian is explaining it really well. I think the main challenge with doing systematic reviews for complex interventions, such as an operation in which you have so many variables that are all over the place, I think trying to make it narrower by focusing on a specific group, we thought it was the right way to go. And I think this diminishes the capacity of this paper to be then maybe applied to other patient subgroups, but at least for the head and neck cancer, I think Sebastian, in this article was able to really put very clearly, well, we can discuss later the results, but at least our findings should be applicable, we think, for that specific cohort of patients, which I think is the most frequent indication for free fibula flap reconstruction.
It's great. Can we get a lot of, as you can imagine, systematic reviews submitted to the journal, and you've mentioned some of the PRISMA criterion and methodology. You use the grade criteria to assess the levels of evidence of each paper. Can you explain for the listeners what that involves?
Firstly, the grade criteria we use to assess the quality of the evidence, and it's also there are different domains. So one of them is risk of bias, inconsistency, indirectness, imprecision, and publication bias. And we could rate this in different levels. So usually high, moderate, low, or very low. And we could see that in our paper there was a moderate certainty. So I would see that our result would be enough to guide practice, but maybe not enough to end this conversation. So it was a moderate quality of evidence.
Great. Let's go on to what you found. So you've managed to go through almost 2,000 abstracts, and you've extracted the 32 studies. You've included 32 studies in your analysis. And most of these were retrospective, but there were actually 10 prospective cohort studies, which is good, and a number of cross-sectional studies too. And so that gave you a total number of 1,163 patients. So quite a big number. Can you tell us what the key findings were from this analysis?
Of course. Of this, as you explained, there was many patients. and this was from 32 included studies. So after the blinded abstract process and the full text blinded screening process, we ended up with 32 included studies. So basically what we found was, so first of all, the mean time for the assessment and for the follow-up was 35 months. And we could also see that it was very, very, very different in the measurements of how you measure both ankle instability but also gait disturbances. And there was both, we gave them two groups. So there was subjective and there was objective measurements. And here where it becomes a little bit confusing, at least for me in the beginning, because we could say that for the subjective, like the most common subjective measurements were the medical records. There were 10 of them, but also that was not the most common way to measure subjective ankle instability, but also gait disturbance. There was with PROM. So there was a validated PROM, which was the American Orthopedic Foot and Ankle Society, which was the most common validated PROM. And for the objective measurements, there was the most common for gait analysis was the Vicon system. And as you hear, there was many different ways to measure, but also different compared to both objective and subjective measurements. And this was I would say it was difficult to divide them. And because in not all of the papers, you could say that this was a subjective measurement of ankle instability and an objective measurement. And the same with gait disturbance. But in total, we could find that ankle instability was found in 32 patients and gait disturbance in 53 patients. And we measured this to be in percentage. So ankle instability was 3.3% of all these 955 free fibula flaps, and for gait disturbance 5.3%. I would say there is a very small minority. If we would round the numbers, 3% and 6% for me is it's very low numbers. But what we found, not only that the risks of these conditions are low, but we could also see there was no a standardized assessment to measure this, and everyone measured this differently. So me and Juan, we discussed how to put this in the paper, and our recommendation for a standardized way of a combined and also a comparable evaluation for these two conditions. So for the subjective assessment of the ankle instability, I would say it's more important to evaluate this condition clinically. So for example, for evaluation of ankle instability, there would be a need for a validate questionnaires, as in some studies, as the American Orthopedic Foot, the PROM, the validated questionnaire. That's what we recommend. But also, it's that type of PROM is not only alone subjective findings, but it also involved some type of clinical examination. And we also wrote in the paper for gait disturbance that we recommend for gait analysis, there is a good system which is called the Vicon system, which we saw in few papers, and it has a very, very high accuracy for gait analysis. So that's how we recommend in these papers to try to have a like a combined evaluation of both subjective and objective, and try to also have a comparable evaluation for future studies.
You mentioned a bit earlier about the possible other subgroups. I think that, and you alluded to in the paper, there's a comment about the pediatric population. Were you able to look at any other subgroups, or was this truly the sort of elderly head and neck squamous cell carcinoma patient group?
Thank you. That's a really good question, because I realize now that we did not have the pediatric population as a specific subgroup. Unfortunately, in this study, we did not write about it, but we included 4 papers in our review. And with that, I want to say, so there was four studies, and in those papers, there was cases which were, there were different type of conditions. So there was trauma, there was benign conditions, and there was also cancer, which was the rare part. So we only found 6 patients in those 4 studies with gait disturbances. So it was around 11%. I want to mention again that this was not included in the study, but we discussed this also, me and Juan, because and I said this before, that if we talk about the population which usually have head and neck cancer, and this paper is specifically about this group, they're usually older, as we talked about, high risk of different wound complications for the donor site, slower rehab, it could be persistent weakness, reduced range of motion, stiffness, etc., etc. Compared to the pediatric population, younger, healthier, maybe better rehabilitation, faster functional recovery, and so on. But we read this on study, and as you, what you also mentioned, Anton, that there were some studies which mentioned the pediatric population which had, for example, valgus deformity or toe contractures or some growth-related skeletal change. But usually these, in those studies we read, the most of these complications disappear, at least within 1 year of rehabilitation. So
it must be a much smaller group of patients, but it's just, so on the one hand, definitely better healing potential, but on the other hand, probably higher demand, issues of growth, and of course most likely a longer post-operative course. So interesting but Lizzie, beyond the scope of you.
I think also that younger patients may be hypermobile. They are more flexible in general terms. They're less stiff than our old head and neck cancer patients, which may reflect then on different scoring differently on the systematic systems, and these are stability assessments. Also, it's one of those confounding factors. At least how the surgeons that do most of these reconstructions do them on head and neck cancer patients. So it would be interesting to know, in hospitals that require fibula flaps for pediatric population, what do they do? Do they go and get the surgeons that would do that for oral cancer? Do they reconstructions for the pediatric population, or do they have a separate team that may not be doing it very frequently? So this is one of the beauties about doing research, is that you answer a question, then you find 10 other questions that are not resolved, and then you can start thinking about how can we address those as well, and what is safe to discuss and make new hypotheses, and what is actually would be safer not to comment on, and to give paper.
Yeah, really interesting study. I was just thinking about it now, to look specifically at the pediatric population, and maybe include, not in this study we included only cancer, but maybe to include all type of fibula flaps for the pediatric population. Could be interesting.
In the pediatric population that require fibula reconstructions for head and neck, because they tend to be other different pathologies as well. So if there are sarcomas, they may also need chemotherapy, more than frequently than the head and neck cancer patients. So again, all those other factors can impact on development, growth, and mobility. So yeah, I think we could discuss the potential findings of another review focusing on the pediatric population. So far I think with Sebastian we can agree that we didn't look into it. We stuck to the bigger cohort.
But let's stick to the bigger cohort that you did actually look into, because whilst it's really interesting to see that and reassuring to see that these numbers of ankle instability and gait disturbance is really quite low, what did you say, 3.3%, 5.5%? But can you get a sense of how detrimental that is for the people who do actually have these donor site problems? Are they rendered unable to walk, or is it just a small nuisance? Can you give us some idea of how bad it is for those who are affected?
I would say it varies, and I would say that most of the patient had some type of symptoms the first half a year, but usually it disappeared after 1 year, and that's what most of the studies wrote. And we did not usually we did not write so much about this in the paper, but it's very interesting to see, because it's all. I also want to say that it's difficult to measure a subjective feeling of, let's say, gait disturbance or ankle instability, and how do you measure the subjective feeling? Because as a feeling for ankle instability for me maybe is different from you, how you feel. So that's why the results were difficult to
Sure, I'm sure. Yeah, it would be a challenge to try and have a scale that everyone could go onto. But I suppose the real question is, what's the alternative? How does this compare to other options you can have for bony reconstruction of head and neck cancers?
No, I think that's the main point of discussing donor site mobility, because every reconstructive strategy comes at a cost. And I think in selecting the right reconstruction for every single patient, there's many, biases that play a role when we select actually what we want to do, including what have we been trained to do and what's our impression or the evidence on donor site mobility. So I was trained in head and neck cancer in Newcastle with Mani Rakbir and Omar Ahmed, who are friends of this podcast. But in Newcastle, we were doing Fibula pretty much 95% of the head and neck bony reconstructions, leaving the DCAA as a backup plan for very selected cases. In Sweden, for example, our friend Andres Rodriguez, also trained in Taiwan, he's been an advocate for using the scapular flap as a reconstructive modality. And one of his reasons for that is that he has seen less donor site mobility, better quality of the vessels. And in his presentations, especially one he gave in Nottingham for one of the JPRAS meetings, he said that what sparked the change was that he had a catastrophic complication with a patient I think had a massive ischemic event affecting the foot that shocked him to the point that he had to change his practice. So in this paper we didn't compare other alternatives, but at least I think with some confidence we can say that at least from a gait and ankle stability point of view, the free fibula flap is a safe flap to perform with an acceptable risk of this specific complication. And we know from previous literature that it's a flap that is reliable, and in my opinion, it's the only flap that can reconstruct the whole mandible. Whether for segmental defect, we would still have the argument of, maybe there's other alternatives that have maybe less of a donor site mobility. Although we'll have to assume that those, like the scapula and DCAA, may have a different kind of mobility associated with them.
I think you've just answered my last question, which was how has this study informed your practice? It seems like we're reassured that the free fibula is the safe or in terms of the risks and benefits as a donor site. Let me finish up then, and thanks so much for both for giving your time to come and talk about this paper. It's a really great paper and hugely relevant. Perhaps in the full disclosure, all of us are enthusiastic head and neck reconstructive surgeons using fibulas, but I think Juan did a good job of presenting the counterpoint. So just pivoting on both Sebastian and Holm and Juan, moving away from your paper, what are you most excited about professionally in the next year? I think, Sebastian, you're on an aesthetic attachment at the moment in Gothenburg, is that right? What else are you looking forward to this year?
Yeah, so I just want to clarify, yes, I'm just doing the aesthetic placement because I have to. So I have to do that to finish my residency, which I'm finishing this year. So I would say that's what I'm most excited about, to finish my residency this year, but also finish my PhD with the help of Juan, of course. So we have some plans for few studies ahead. Also actually looking now for a microsurgical fellowship. So I'm looking for that right now. Also with some help from Juan, hopefully, to get some advice, what to look for and so on. And also attending the JPRAS. That's what I'm planning for this year.
Okay, it's a lot going on. Wow, fun.
Well, he's got an exciting life. I totally make sound that, you make it seem that your aesthetic attachment is like, what's in post, and I'm sure you can definitely enjoy that, and all what you're going to learn is going to then influence your reconstructive practice as well, Sebastian. Well, I mean, a unit in San Antonio that you're very familiar with, Dr. Free. So I'm not doing so much head and neck cancer anymore because of here it's that we have a strong ENT department that do it very well. However, I still do my bony reconstructions for our orthopedic colleagues. We have set up an orthoplastics unit with a strong collaboration, and we are getting, I think, very good results in the management of open fractures and complex trauma. For next year, we plan to continue growing in terms of people, but also hopefully get some good data of what we've done so far, so we can continue to improve. I put the name of San Antonio out there in the world of microsurgery and reconstruction in general. And I'm looking forward to publish more papers in JPRAS and JPRAS Open.
Any technical refinements that you can advise us on how to reduce the donor site morbidity when we're harvesting the fibula flap?
So commenting on the fibula flap technique, there has been two different approaches described: the anterior approach and the posterior approach. And I've only done the anterior approach, which is what I got trained to do. I think we should have some considerations. Are first the planning. You should try to keep at least a minimum of 6 centimeters of the distal fibula, which is the part which is in close relationship with the syndesmosis and provides ankle stability. I tend to leave 8 just to be on the safe side. You can leave less than that, but then you definitely have to put a syndesmotic screw across the ankle. But I never had to do that because I've never had to breach that kind of line. I would say also, not commented in terms of gait instability and ankle stability and gait disturbances. The common peroneal nerve runs in close relationship to the head of the fibula. So I would also leave the head of the fibula untouched if I can, to try to prevent a neuropraxia or an injury to the common peroneal nerve. In regards to the management of the donor side, if you take a skin paddle of less than 4 centimeters, usually you can flush primarily. If you take any more, you're probably looking at a skin graft. And I think it's worth spending some time. Sometimes if the attending or consultant is doing the microsurgery, the most junior person gets to close the donor side. I would advocate for paying a bit of attention. It's an important part of the surgery to make sure that the lateral compartment is well prepared for accepting a skin graft in the area, and that will reduce, delayed healing in the future. I think splinting, although not required, I think it's beneficial for optimizing graft take to splint the ankle and prevent, I would say, Achilles tightening. For the ones that happen to be members of JPRAS, there is a video on how to raise the fibula flap done by Adam Blackburn and supervised by Manny Ragbir, which is available for JPRAS members because it won the Baron's Prize. So I would definitely go back to that video for revision, FRCS, or any boards, because it's very well described and it mentions these tips and tricks to avoid getting in trouble.
Fantastic. Guys, thank you so much.
Okay, that was great. James, what did you think about that?
Well, it's so exciting to hear about people talking about donor site morbidity. We always talk about we're excited about flap reconstruction for complex defects, but we often forget about the donor site. Anton, you've done loads of fibula flaps. What do you think? Has that changed your way of thinking about this donor site?
Yeah, it's very interesting, isn't it? And I think, as microsurgery's evolved over the last sort of, 20, 30 years, we've moved from, desperately hoping our free flaps would live to, really finessing our outcomes in terms of, the aesthetic or the functional reconstruction we're able to achieve with free flaps. And now I think, we're moving into a stage where, we're really paying a lot of attention to donor sites as well. And I think it's a real part of how microsurgery's evolved. Fibula flap, certainly, in my hands at least, it can be a challenging donor site. And it can be, often sometimes you see some delayed healing, and of course you kind of accept that in the sense that there's really no other way to reconstruct, segmental head and neck defects, bony defects in irradiated fields, etc. And so, you accept that trade-off, but anything we can do to improve that donor site is very important. And actually, I think some of their data was quite reassuring that actually, in the long term, patients do pretty well. So at least, when you're having these discussions with patients and their eyes do sometimes light up when you say that you're going to take 20 centimeters of bone out of their leg, you can actually turn around and say, in the long term, this will be pretty good.
Yeah, I mean, I guess it's a needs must situation, isn't it? But the question is, how do we identify patients who might have problems and deal with that quickly? And I think that's something that Juan talked about really elegantly, I thought, to try and get on top of the problem before it becomes a real issue.
Yeah, absolutely. The patient selection, some critical points about that. Fantastic. Well, thanks, James.
Thank you, Anton.
And until the next time,
the rest is plastics.